of February 19th, 2025. We have two agenda items today. UVM-MC has submitted a request for an adjustment to its fiscal year 25 budget, and we also have hospital fiscal year 26 budget guidance and an overview presentation from Health Systems Finance. Matt, I believe you're the presenter for both of those. Is there one you'd like to take up first?
Sure. I think we're going to start with the UVM mid-year request. Maybe our slides loaded.
While we do that, I'll move for approval of the board minutes from our February 5th meeting.
Second.
All right, and all in favor, say aye.
Aye.
Okay,
Aye.
great. Aye, and the minutes are approved, and I'll turn it to Matt.
Thanks, Chair Foster. We have a pretty short agenda. We're just going to go through the UVM Medical Center's mid-year request. We'll start by going through statute, rule, and policy. I'm going to have some help from Julia on this. And I'll present a summary of their request and provide some potential motion language when and if the board's ready for a vote. So if I can just pass it to Julia real quick to go through the statute, rule, and policy.
Yeah, so I'm just going to give an overview here of the language that we have. So in 18 VSA 9456, that's the standard that the board's going to look at. This language, it states that the board can adjust a budget upon showing of need based on exceptional or unforeseen circumstances. We also have language in our rule 3.401A. That rule outlines the factors that the board will take into consideration with a budget adjustment request. And you can see here on the slide, there's several different factors that the board is going to be taking into consideration. And then we also have, in addition to those two, we have our budget amendments and adjustments policy. And that language in the policy states that you can have a budget amendment to account for unanticipated changes to an approved budget. Thank you.
Thanks, Julia. So moving ahead to their request, just very quick summary. During the FY25 budget process, the board reduced the medical center's allowed NPR growth. To comply with that order, UVM made several decisions, one of which was an attempt to offload dialysis services for patients of Northwestern Medical Center, Rutland Regional Medical Center, and North Country Hospital. These services were projected to bring in roughly $5.7 million in revenue against $10.1 million in expenses, or about a $4.4 million loss. Since they did not immediately shutter the services. They've just been attempting to find a partner hospital able to take on the work. They have been unable to do so far. As you saw, there's a net loss associated with these services that others aren't able to take on, and they're unable to provide. They're asserting that they're unable to provide services at lower cost. UVM Medical Center is asking the board modify their approved budget by the amount, their NPR budget by the amount of revenue projected for these dialysis services of $5.68 million. This corresponds to about 0.3% increase to their overall NPR. And the medical center is asserting that that their request meets the requirements established in statute and the rule. That is what we have prepared. Here's potential motion language when and if the board is ready to address the request. And then just open, I guess, for board discussion questions.
Thank you, Matt, and thank you, Julia, for the overview. I don't have any questions at this time. I appreciate UVM having taken what I understand to be a significant amount of effort to see if there's a place where this could be done more cost effectively. But I don't have any questions or other comments at this time, so I'll open up to the other board members.
Guess I could go for a minute. So I'm trying to understand this. So we set an NPR cap, and historically, my understanding is Vermont that there's been a regulation of NPR for for decades. And that is to control the expense growth in healthcare costs. I appreciate UVM's work on trying to find someone else to provide these services. I think that this has been really challenging for a lot of patients in Vermont who've been concerned that their dialysis could get cut off, that they potentially have to move. They may not have the ability to move, the means to move. You can't really move right now. So this has been a huge hardship for so many Vermonters to try to figure out how to access this care. This is, you know, for nearly all patients in dialysis, this is a 3-day-a-week commitment. Several hours a day, sometimes early in the morning. And missed dialysis can be catastrophic. So this becomes part of your life. It's a rhythm. My uncle's on dialysis. He's been on dialysis for years. It's just a huge part of what he does with his life. And to have that thrown up in the air and questioned, I think has been really challenging for a lot of people and really, really painfully hard. I guess my other question, this gets to the question of why not consider reducing commercial prices on high price items like imaging to lower your NPR to come in at the NPR cap. And my assumed answer to that would be that there would be something about, well, we wouldn't be able to make the margin that we need to do to provide the services that we need to provide, invest in our organization and our communities. But I think at this point, given the crisis of cost, affordability, insurance prices, impacts on property taxes, it may be a time where the risk might be better to have a slightly lower margin than to bring this cost back into the rest of commercial costs. So I would like to know, something on that. And I think since we're talking about services that lose money like dialysis, I mean, there's no, it's no illusion that there aren't other services that lose money too. Commonly, when I got to UVM and worked there, started working there over about a decade ago, I guess, there was discussion of pediatrics as a service that loses money. So that's why we need to subsidize pediatrics. But OBGYN, psychiatry, as we've learned with CVMC over the years, loses money. Primary care often comes up as a service that's break even or loses money. This is not a UVM thing. This is how the financial equation of hospitals works. Some services make money, some services lose money, and through the process of charitable nonprofit organization, the goal is to deliver healthcare at a way that people can afford. So I guess I would like to learn some similar information about how about the top 3 services that UVM Medical Center has, the biggest margin earners, total dollar margin earners. What's the revenue, what's the expenses, and what's the margin? Because we're learning about services that lose money, but we're not learning about the services that make money. And I think it would be nice to understand that balance when we look at this information.
Any other board member questions or comments?
This is Tom. I think Dave was getting at some of my questions as well. I think of revenue as being a product of the volume of services multiplied by their price. And so I was wondering if I would like to see information on the volume of dialysis services? Are they rising? Do they fluctuate very much? Or have they been relatively consistent in Vermont? How predictable are they? If that number is rather predictable, as I suspect it may be, because as Dave pointed out, these are patients that receive the same care the same way 3 times a week, sometimes for years. The obvious other way to reduce revenue would be to reduce price somewhere else. And we have seen through the past several years of budget hearings that this hospital and health system have very high prices that have risen much faster than other places in the country. So I'm not convinced as yet, although I'm open to be, I'm not yet convinced that there's not a way to reduce price elsewhere to stay within the revenue cap that was sent. $6 million is a lot of money, but it's a relatively small portion of the budget that we review. And it would seem that a very minor price reduction in a high volume, high priced service area could achieve the result the system is aiming for with this request.
There's a phone that maybe should be muted. 7729. Yeah, thank you. All right, any other board member questions or comments at this time? All right, I'm going to, it's not clear to me whether or not we're prepared to vote, but I'm going to make the motion, see if there's a second so we can take public comment on the motion itself. And if we're not prepared to vote, and I recognize there's some follow-up questions that have been raised today. So I'm not anticipating that we get to the vote necessarily, but I do want to open it up, see if there's a second, and then we can take public comment on the motion, of which if we vote later will be beneficial. So I move to approve UVMMC's request for a budget adjustment to their fiscal year 25 budget to allow a total NPR of not more than $1,903,520,112, subject to the same other conditions and limitations as set forth in UVMMC's fiscal year 25 budget order.
I'll second for the purposes of public comment.
Right. Is there any other board comment or discussion on the motion? And if not, I'll call for public comment via the raise the hand function, and I'll start with the healthcare advocate.
Thank you, Chair Foster. I see that the court reporter is here today, or I thought I saw that. So my name is Eric Schulteis. I'm a staff attorney at the Office of the Healthcare Advocate. So I'm not going to address, other than simply mention it now, that this request is for an upward adjustment of only 0.3% to approved NPR, or that Dr. Eapen's bonus last year was 13.3% of the loss the medical center claims it will experience providing the services at issue. Rather, I want to talk a bit about the events that got us to this point, whether the outcome could have been reasonably foreseen, and what granting this request would mean for the hospital budget process in the future. So let's take a moment to refresh our memories about how we got here. First, In September of 2022, the board approved a 10% NPR increase for 2023 and a 14.77% commercial effective rate increase for the medical center. Let's not make any mistakes. Vermonters pay for those increases, whether via higher insurance premiums, higher state taxes used to fund the health insurance of our public servants, and/or higher property taxes to pay for the health insurance of our school workers. Vermont businesses also pay for those premiums, and it trickles down to employees whose benefits or compensation doesn't increase because businesses look at the total compensation package, not just the wage. So second, the medical center violated this order by 4.8%. Or put differently, the medical center's revenue was $80.3 million more than was allowed. Next, the board issued a budget enforcement order as the medical center's overage was substantial, and each hospital is required to live within its budget for the good of all Vermonters. To avoid too much shock to the medical center related to the enforcement order, the board required that the medical center pay back the overage over 2 years, instead of just making it pay it all back in 2025. Lastly, in response to the enforcement order, which was itself a foreseeable consequence of substantially violating an ordered budget, the medical decided to cut several Vermont services and vocally tell its staff and the public that the board had forced it to cut services. Our office does not believe this is true. There were many other revenue control measures the medical center could have used to comply with the enforcement order instead of cutting services. One of the services the medical center chose to cut is at issue today, namely dialysis services provided by the medical center at various other hospitals across the state. I'm going to speak to whether the extra revenue from this service is a foreseeable consequence of the medical center's initial cut of this service. After a relatively quick announcement of the service cut, the medical center spent a few months engaging in some unknown negotiations with the hospitals at which it provides these services. As I hope most reasonable and informed people would conclude, it was unlikely that one of these financially weaker hospitals would be able to take on the service at the drop of a hat. In fact, no hospital was able to take on these services in the short time frame the medical center's actions had necessitated. Was this truly unforeseeable? If a hospital abruptly cuts the service, is it likely that a financially weaker hospitals could abruptly take on providing that service? Equally importantly, the root cause of the need for other hospitals to abruptly take on the service was itself the foreseeable consequence of the medical center's decision. To use what I think is an apt metaphor, albeit overly legalistic, what the medical center now seeks to do is like a violation of the maxim of equity, that he who comes into equity must come with clean hands. So equally important as foreseeability, I want to talk about what it would mean if the board grants this budget adjustment. So what would the board be saying in granting this? The board would be saying that if a hospital violates a budget order, that the hospital can functionally undo a budget order enforcement so long as the hospital cuts services instead of implementing revenue control measures. Setting that precedent alone is reason enough to deny the adjustment. Thank you.
Thank you, Mr. Schultheis. Any other public comment at this time? I see admin at Essex, which I believe is Alex Leclerc. Mr. Leclerc, how are you?
Good. How are you, Owen?
Well, thank you.
I just have a couple of points that I want to make about this. One, the bonus payments that the leadership got is basically what they're asking for. I'm just wondering if they could have donated that back to the hospital, would be my first point. Second point, using the price transparency at UVM's website, I'm a PT billing nerd. I know what it's going to cost me to come to my clinic and all the other clinics. If I went to PT at UVM, my eval code is going to be $312. But if I use my self-pay, don't use my insurance, it's somehow $196. So it's cheaper to not use my health insurance and get PT at UVM. I don't know how we have allowed this to happen. And it's pretty clear that the revenue, they have the revenue and they can adjust it as they see fit. And the previous speaker echoes my words times 1,000. This is so frustrating as a 30-year-old who next year when these tax credits go away from the federal government, probably going to happen, a bunch of people like me are going to contemplate whether or not to have health insurance because it's going to cost a minimum of $16,000 for the catastrophic bronze premium level. I have not gotten a raise in 2.5 years because I want my employees to get raises before me. This system is not sustainable, and UVM controls 40 to 50% of the revenue in the state. We cannot let this happen. And I was a young kid when all of this happened, but I can no longer sit silent and just watch this eat at the whole healthcare system. Thank you.
Thank you, Alex. Walter?
Hi, Owen.
Hey.
The previous two speakers echoed what I was going to say, so I won't be redundant about it. I will say that I'm on Medicare. I lived that long to be on Medicare somehow, and the supplemental policy went up, just shot up $40 this year. So it's 40 extra bucks a month I have to pay for that. It went from $195 to $235. And that is largely because of hospital expenses and largely because, as the previous speaker said, UVM controls so much of the market. I'm getting tired of healthcare being a market. But in any case, the second issue is I've been working with people in the Mad River Valley where UVM is closing the Mad River Valley office. And they're wondering why, especially when UVM had like 80 billion in extra revenue, 80 million in extra revenue, could afford all of these lucrative bonuses for the top people, has a top payroll of something like 11 million, if I remember right, and is investing so much money in New York State. So I agree with the previous speakers about this hospital budget increase, that it's sending a message to the hospitals, especially UVM, or its leadership, that they can just run rampant over this and over us too, who are paying for all of this. So many Vermont workers make 15 to 20 bucks an hour, and we don't get raises either. Gonna get this.
Thank you, Walter. Any other public comment at this time? It think I'm going to hold off on the motion, given that there's a couple outstanding board requests. So I will table it and we'll work with our staff to see if there's a couple additional questions that we could get information on from UVM. And I anticipate trying to take this up again in short order if we're able to. So thank you, Matt and the team, for your presentation today. Turning back to Matt, we have our hospital fiscal year 26 guidance overview.
Thanks, Chair Foster. Let me just get the slide deck loaded. All right, does that look all right, everyone?
Yes.
All right, so thanks everyone. This is our initial staff presentation of the FY26 hospital budget guidance. So just a quick agenda for today. I'm going to go through a summary of the review process, an introduction and purpose of today's meeting. Mark Hensley is going to walk us through some statute and rule related to the hospital budget process. Then I'll go over a timeline. After that, we'll jump right into guidance and reporting requirements this year with a focus primarily on the Section 1 benchmarks, but we'll also review the subsequent sections and their intent and purpose. Also available on the website now is this presentation and the draft guidance document. So annually, the Green Mountain Care Board reviews and establishes budgets for Vermont hospitals. These budgets are developed by hospitals in the spring and submitted to the board by July 1st. By the end of March, the board issues guidance to hospitals outlining expected growth benchmarks and the process by which their budgets will be considered. The purpose of today's meeting is to present to the board, regulated entities, and the public staff's draft of FY26 budget guidance and open it up for public comment. I see Mark, I'll pass it over to you to walk through the statute.
I can fly through this. Thanks, Matt. So I just want to touch base on what the statute says about benchmarks and about peer group norms, and just define what each of these are, because they're going to be relevant to Section 1 and Section 2 of the guidance document as Matt gets into both of those sections. So starting point, board establishes a budget by September 15th, written decision by October 1st. What the statute describes as a process that the board may use to define criteria for hospitals to meet, which are called benchmarks. And the idea is that if a hospital meets benchmarks, then the board may waive one or more of the areas of review that are listed in statute. Separately, the statute describes in the section on the establishment of hospital budgets the requirement that each established hospital budget take into consideration national, regional, or in-state peer group norms according to indicators, ratios, and statistics established by the board. So one of the things we're doing today is we're talking about benchmarks, which are about whether or not the board can waive review of certain criteria. And we're also talking about these peer group norms and indicators and ratios, statistics that get established by the board. And what we do is we establish those in the guidance process. Feel free to hop to the next slide, Matt. Thanks. So just to look at the rule briefly, GMCB Rule 3.202A states that the GMCB will establish benchmarks for hospital use in developing and preparing the upcoming year's fiscal budgets. Part of this process involves meeting with VAHS and interested persons to obtain input. Staff did that last week. And then benchmarks get established by March 31st with the guidance document. The benchmarks allow the board to determine whether to adjust a hospital's proposed budget. And the board can set benchmarks for growth indicators, cost and price indicators, and other financial measures. I think there are about 13 different kinds of benchmark categories that are listed in Rule 3.202C. So that's all going to be relevant to Section 1, which is where we're going next.
Thanks, Mark. So just real quick, we have a timeline, a more detailed timeline you'll see on the left. This is just a screenshot from the guidance document that we posted today. Very quickly, though, some upcoming highlights. So public comment period, the formal public comment period for guidance opens today through March 25th. Before the board intends to vote on guidance. 3 weeks from today, we will be presenting revised guidance to the board. The idea is we'll take any feedback from board members, questions, public comment, and edit and present revised guidance at that time. And then 5 weeks from today is when we have scheduled for a board vote. So real quick, let's just jump into the benchmarks. So this year we're similar to last year, we're establishing commercial reimbursement growth, increase of 3% by payer. I'll pause there just for a second. You'll see this commercial reimbursement language in there. We're trying to be a little bit more precise in some of our language. What we're referring to is the same thing we were referring to last year. It's just we're trying to be a little bit more technically specific. It's not always price that's increasing. Sometimes it could be it could reduce the commercial discounts. So you're not technically increasing the price, you're reducing the discounts, but it's effectively similar. There's also fee schedule stuff where it might increase but not have an impact on price. So really it's more of a technical specificity, technical change here. But if you have any questions about why we're using the word reimbursement, that's why. So the 3% we're suggesting here in the draft benchmark is tied to the consumer price index, similar to what it was last year. The most recent January update just came out, I believe, last week, and it was 3% over the prior year. I see, Dave, your hand's up. Sorry.
Is it all right if I just ask a quick clarification on price, just because? So my understanding when we use the term price is not charge, but is actually the total allowed amount. Is that, and then so I think when you say commercial reimbursement growth, we're saying the aggregate of the total allowed amount.
Yes, that's what I'm intending. I think there might be some more, technical precision there, which we can get you a really precise definition. But yeah, Dave, that's
okay. Is that including utilization?
Right? No.
Okay.
Yeah, it would be distinct of that, and we would we'll get into that, but we're still going to use the same rate decomposition workbook, update it a little bit, but to break out reimbursement from changes from utilization from payer mix. So we see the impact there. We also looked at some other approaches for benchmarking price. One approach is to look at the market basket increase, which this year was 2.9%, so very similar to what we're seeing with CPI. Real quick, just to look at what was requested, approved last year, and then how a 3% universal NPR guidance would look this year, and like considering that with the enforcement actions we took last year. So you'll see last year an aggregate that requested an average of 5.6%. The board approved 3.3. When you factor in enforcement, that brings it down to under 1% increase. If we set it at 3%, the way it shakes out with enforcement at UVM and Rutland is it would reduce the reimbursement increase component from 3 to about 0.5% estimated. And the system-wide average is just found it's a weighted average. So just so everyone's aware, you just take the rate increase times their share of system-wide gross revenue and just allocate it proportionally there. Here's just a look at what rate increases the board approved in comparison to what CPI increases have been over the last several years. So you see in 21, 22 kind of in line, and 23 a big variation there. Next is a pretty standard benchmark we've used, net patient revenue growth. Staff's recommending this at 3.5%, a continuation of the target established in the all-payer model. And looking at this, here's what was established in budget. Here's what that 3.5% would look like this year. Here's the delta in dollars and percentages. And then just to show kind of the impact of that on like a compounding basis, if you look at the FY22 to FY25 compounding growth in NPR, it's at about 7.1% a year since 22. If complying with a 3.5% increase across the board would reduce the compound growth rate from 22 to 6.2%. So yeah, and the last benchmark is a new one for this year, different. I think we've had one several years in the past, but in the near recent history, this is new. Is establishing an operating expense growth benchmark, and the goal here is to more directly target expense management. NPR obviously gets to this somewhat indirectly, but we wanted to establish a more specific operating expense growth benchmark. Similar to how I showed NPR, here is OpEx budget guidance with a 3% increase, what that is in dollars and percentages, and then the compounding growth impact of that. Real quick, I just wanted to stop for a second on the operating expense benchmark, since this is relatively new. Staff's asking for, obviously we would welcome and love receiving public comment and thoughts on anything in here, but specifically we're asking for thoughts on the operating expense benchmark. Some questions we're working through, are certain expenses illogical to exclude from a growth calculation? So pharmacy expenses that have directly attributable revenue could be an example. Provider taxes are kind of outside of control of expense management in a way. I guess you could indirectly reduce revenue, but just thinking logically about certain expenses, if we want to adopt an OpEx benchmark, that would make sense to hold them harmless for or exempt from. Also, we've seen wildly different expense growth between hospitals, from below 1% at a hospital like Rutland to over, I think 6.5% at the medical center. Looking at it on a compounding basis since 22. So should hospital benchmarks vary depending on recent expense growth trends? And then also, how would setting an operating expense benchmark impact critical access hospitals who are reimbursed on costs? So just some things that we're working through that I think need addressing if we're intend to adopt an OpEx benchmark. Jumping ahead to section 2, this is a comparative analytics section, kind of similar to last year, where if the hospital is not beating benchmarks established by the board, we outline measures, sources, peer groups that we use for further analysis of their budget. And there's a direct link here, but the metrics inventory is available on our website now, the first draft of that. I'll also pause to add any changes that we're going to make to guidance, the metrics inventory, rate decomposition workbook, anything we're sharing today. We're going to have a change log available on the website so that everyone's aware of any adjustments we're making between now and when we present revised budget. Section 3 would be reviewing assumptions. So staff will test the rationality of the hospital's assumptions and its proposed budget, confirming accuracy of calculations, comparing to prior year experience. You can also test the hospital budget by comparing to external data sources. I'll pass it to Mark. I think we made some updates to section 4. He's going to walk through some of the statutory analysis the board conducts.
Yeah, this part should be pretty straightforward. Last year, section 4 had some material that was either removed or consolidated with the metrics inventory that's now on the website for section 2. So what we're doing with section 4 is we're just making explicit something that's been true forever, which is that when the board is reviewing hospital budgets, part of its process is to walk through statutory analysis. And in particular, this section just defines in the guidance document the items under 9456C that the board is required to include in any established budget. So in addition to those peer groups and indicators that the board establishes under section 2, the budget must be consistent with the health resource allocation plan, must promote efficient and economic operation of the hospital, reflect budget performance for prior years, reflect public payer and bad debt or charity care assumptions, and demonstrate equal access to appropriate mental health care. Those are all just in statute. So this section just defines the areas that the board is looking at, and it also explains that regardless of whether or not a hospital meets the benchmarks and whether those benchmarks again guide the board in determining whether or not to adjust a budget. Section 4 is in part about the board's review of these other areas to determine whether or not additional budget conditions need to be included for a particular hospital. So a hospital might meet benchmarks, the board might choose that doesn't need to see a modification to its budget, but for reasons like efficient and economic operation of the hospital, or for other reasons here, the board might establish specific budget order conditions in the budget order. So that's what section 4 is this year.
Great, thank you, Mark. Moving to section 5, this outlines questions to be answered in narrative form in the budget narrative. This includes things like explanation for variances between budget, projection actuals, justification for deviations from guidance, specific programmatic or operational questions, and any explanation or background for assumptions in the budget, among other things. I think we are going to be making some changes here where some budget narrative questions that we asked last year might be moved into like a more workbook format this year, just to ensure some more like consistent responses. But by and large, that's what section 5 looks like. And then section 6 outlines reporting requirements. So submission requirements, deadlines, filing methods, etc. I did want to flag New Year's this year. We're trying to improve routes of communication and way we're submitting materials. So all budget materials that aren't directly input into adaptive worksheets. So those like standard financial tables that hospitals enter like their income statement, their balance sheet, that kind of data into. Supplemental workbooks, other forms like that, they'll be submitted to a new dedicated GMCB submissions inbox. And that way we can better monitor submissions and ensure that healthcare advocates receiving all the information we receive. So next steps, today, draft guidance materials have been posted to the website. We have the guidance document, the metrics inventory, the rate decomposition workbooks available. We're still working on some other supplemental workbook materials we need, but the rate decomposition workbook is so integral to us understanding the impact of reimbursement against utilization, against payer mix. We wanted to get that out well in advance. And ongoing will be public comment. And then, as I mentioned, 3 weeks from now, staff will present revised guidance and provide all material in anticipation of a vote 2 weeks from then. So 5 weeks from today. Now I can pass it back to Chair Foster.
Thank you very much, Matt. I have nothing myself. So any board member questions or comments?
I had one question. I know that VAS has been working on a data dictionary that includes measurement and benchmarking, and I wondered if anyone's taken a look at that, wherever that is in process compared to the metrics that we're looking at. I'd just be curious about the overlap.
Yeah. Thanks, Rob. That's great. I meant to mention this, and you jogged my memory. I'm actually meeting with VAS tomorrow to look over some of the material they're working on. They were nice enough to send over some. There's definitely going to be overlap with the metrics inventory and a lot of the data dictionary they're working on. So something that I'm really pushing to do, and I think everyone's probably on board with this. I want to make sure anywhere we have metrics that we're all using, we have a shared definition, a shared understanding of how they're calculated. Yeah, I think definitely wanting to make sure those are in alignment.
Thanks.
Hey, Matt, thanks for this today. Real quick question is there a way to tease out within the utilization bucket, utilization versus changes in coding intensity? Or are those both get lumped into utilization?
That is a great question, and I shouldn't answer that on the fly. Could we get back to you with a better answer?
Totally. I think the short answer is it's going to be really hard.
I think so too. Yeah.
But I wonder if we could come up with some indices to think about it, like actual volume, understanding volume and utilization and how they're different, and the difference might be coding intensity. But I'm sure there's people who know a lot more about this than I.
My initial thought is it might be difficult with how we use the rate decomposition workbook to include it there, but I'm wondering if there's other ways we could get at kind of understanding the impact there, or breaking out utilization a little better. But yeah, you can definitely look into it.
Matt, I'll just thank you so much for the presentation, and the whole team. I can tell there's been a lot of work that's gone into the draft guidance already. I guess I would just say I'll flag. I'd love to carve out some time on my calendar in the next, week or two. Maybe you could just schedule with me. I have some thoughts, but it's, still half baked. Some of the language, but also some things that I think maybe we might consider. So just want to put a placeholder in that I appreciate all this work, and I'd love to connect with you all on some ideas in the actual document.
That'll be great. We'll definitely do that. And I think that was one of our goals of getting the guidance document out, even in draft format early, was so we could have like a point of reference to have these conversations around. So happy, love that, Jess. Yep.
Hi, Matt, this is Tom. I want to join my fellow board members in thanking you for the work and the team's work on this. You mentioned for operating expense, one of the questions that you were considering was, do we consider operating growth over time, because there's wide variability. And I know it's not directly analogous, but I'm wondering if there's been any discussion or your team has thought about different NPR growth targets based on hospital characteristics, instead of having one uniform target across all hospitals, having a different target for different types of hospitals.
Yeah, we've definitely considered it. I don't know that we have anything to share publicly. It becomes like anything in healthcare, it becomes complicated modeling the differences and nuances. But yes, it's something we've definitely been considering. I mean, you can see big changes in variation in the approved rates also, right? It's not just expenses. So it's something we want to look into more. Yeah, but I don't think it's ready for this year's budget cycle, would be my opinion.
Okay. Well, thank you for that. As Jess was just saying, I'd appreciate talking with you more about it, learning more about what you've been discussing.
Yeah, happy to.
Any public comment? I'm sorry, let me go to the healthcare advocate first and then public comment.
Nothing from us at this time. We'll do written comments. Thank you.
Thank you. And public comment via raise the hand function. Patrick Rooney.
Thank you, Mr. Chair. Can you hear me?
Yes, sir.
Great. Thank you. Patrick Rooney, Vermont Association of Hospitals and Health Systems. I just want to thank Matt and the team for the work they've done to date. We are looking forward to the conversation tomorrow. But specific to these materials, I just want to hop on a couple of points here, having just reviewed them over the course of the last few minutes. I think that we need to get down to a solid, consistent place of definition when it comes to what the board is looking to regulate on the commercial rate side. We've had terms like commercial rate, commercial negotiated rate, now it's commercial reimbursement rate, several iterations of, I think, what are sometimes thought of as the same thing. And our conversation with the staff last week between the staff, hospitals, and VAHHS was that we really got to come to a place of consistency there. And when Board Member Merman is asking for clarification on that, I think that highlights, underlines, and bolds the need to do that. The Uniform Reporting Manual per the hospital budget rule is to have these benchmarks identified in it. That was not the case last year. Given how substantive and precise the Uniform Reporting Manual is, that would be a great spot to park a definition for commercial reimbursement rate, commercial negotiated rate, whatever it is you're trying to get to. Even in the last week, we've had a change in that benchmark. It was proposed to us as commercial price increase, which tipped off that conversation that I just discussed, and now it's commercial reimbursement rate. So we really need to dial this in. It is a formative part of what you're looking to do to control commercial rate growth and costs. So it really warrants the need to have a very clear, defined definition of what it is you're looking to do, and to maintain that throughout the process so we don't find ourselves playing with language in September that doesn't correspond with the guidance and the directive set by the board when guidance is put forward on March 31st. I do want to make one note. Attorney Hengsler went over it pretty quickly. We did meet last week for an hour with the staff, but at that time we had a scaled down slide deck to react to. So we didn't really have the materials that are present now on the website to provide input on. That was very high level. We had some good conversations with the staff on the direction they look to go in. But I think there's room there in the future to have more substantive conversations to obtain real input per the charge in the hospital budget rule. But in that space, look forward to reviewing this stuff further and keeping those conversations going with the staff. And to Robin's point, trying to find some alignment on performance measurables and metrics. So thank you for the time today.
Thank you for your comment. Any other public comment? Great. Matt, yes, thank you very much for you and your team. I know with the legislative session, everything else you have going on, you guys have really been, as always, working a lot of overtime. So thank you for getting this to us early. There's a lot of time for comment and input between now and when we vote on it. So I appreciate you really pushing this up. And I know you guys are really working hard. So thank you very much. That is all we have on the calendar for today. Is there any new or old business for the board?
Actually, I have a old business item today.
Floor is yours.
So this goes back to 2023. So in July of 2023, I started working with the Ethics Commission on an opinion about my involvement with the UVMMC budget decision. So quick context, my wife and I are both emergency physicians. We both work clinically at CVMC, both used to work at UVM clinically. I do this, and my wife works in medical informatics for the medical group. And so we were trying to figure out at the time whether or not, looking at the state ethics codes, whether or not it would be appropriate for me to participate in the UVMMC budget hearing for FY24. And I sought guidance from the Ethics Commission, and in that guidance, my impression at the time, asked my supervisor, colleagues, several other supervisor levels up, one supervisor level up, whether or not I could receive bonus compensation. And there was a general agreement that no, there was no opportunity for me to receive bonus compensation in FY24 as far as we knew. So when the Ethics Commission report came out, some people at UVM said, no, you actually can receive bonus compensation. And in the FY24 compensation manual, there is an opportunity if the network made a margin above the predicted margin, that there would be an opportunity for physicians to make bonus. That's my understanding. If they exceeded their budgeted margin, there's an opportunity for physicians to make a bonus. And there were several requirements for that. There had to be some sort of plan in place or whatnot. So it's pretty clear to me that I wouldn't get a bonus from everyone I spoke with who would pay me. But But I went ahead and in a disclosure statement, I said that I'll read what I said actually, to the extent we are eligible or did receive any variable compensation or bonuses for FY24, we would direct the UVM-HN medical group to send those funds to charity care or to community health organizations. Okay, so fast forward, and so that's a statement that I made in 23. I ended up abstaining from the 24 budget vote. It seemed like there was just too many unknowns at the time regarding this. I've subsequently gone back to the Ethics Commission and included that there is an opportunity for variable compensation, and they still found similarly that is not impactful and that it is okay for me to, their opinion is that it'd be okay for me to continue to participate in the UVM MC budget hearings. So on December 5th of last year, I received an email announcing that I was receiving incentive compensation due to a network exceeding its budgeted margin by 0.8%. So on December 6th, I asked for a stop payment on this so we could sort out what's going on for both my wife and I. We have been working with the business office and the UVM HN emergency department to try to figure out what can be done. Can we direct these payments directly from UVM to charity? On January 16th, I was told my options were to either receive the payment for my wife and I to receive the payment or to forfeit it to the UVM Health Network. And my wife and I both agreed that we would rather receive the payment and that we would donate the gross pre-tax, that's what comes in the budget, that's what comes in your email saying what your budget is, to charity. And so we haven't quite properly received the payments yet. It's got a little bit mixed up, I think, with all the hiccups in this, but we are planning on, we've identified 2 charities that we are going to give this money to. 2/3 we're going to give it to the Good Samaritan, Haven and Barrie, and I don't know if you're familiar with the Good Samaritan in Barrie, but they do an incredible amount of work with people without housing. It's a huge community asset, but it's, like anything else right now, incredibly strained. And then also another way, which is in Montpelier, is a community organization that works to among many things. They do a lot of work with a peer-based alternative for mental health services. But they do, my understanding is they do a lot of work with providing meals for a lot of people who can't find other sources of food. So, so I just wanted to, be totally transparent as to what's happening. That I did receive a bonus payment that we are. I was unable to not receive it without it, I think, staying at UVM, and I felt that it was more appropriate to receive it and then donate the gross amount out to charity, which was the intention in that statement in 23. So happy to answer any questions anybody has about this. It's in a process.
I don't think we need a vote for that, but I think we all applaud it and appreciate it very much, Dave.
Thanks.
And thank you for raising it.
There's a lot of need right now.
Well, thank you. Okay, if there's no other new or old business, I will move that we adjourn.
Second.
All in favor, say aye.
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 Aye, and we're adjourned. Everyone, please have a nice day. Thank you.